Good afternoon, right coast. Good morning, left coast. Good day, world. My name is Vernon Vincent, and I am very pleased to be your moderator for today's Reshape Life Sciences Lap Band Aftercare Best Practices webinar. We are humbled to have such a great turnout today with nearly 170 attendees and many others who have asked for the video of the event after it's over. Welcome attendees live from Italy, the Netherlands, France, and a large contingent from the UK, and of course, all over the United States. Among you, we are honored to have a past president of IFSO and a past president of the ASMBS with us today. As always, my personal goal and obligation is to make this time worth your time. With that, let's get into it. Our topic today is best practices aftercare to achieve the best possible results for our lap band patients. We have an expert panel with years of experience with thousands of lap bands, not just putting them in, but continuing to provide the comprehensive long-term care that is required. Next slide, please. A few housekeeping details. All attendees are in a muted and we can't see you, so relax. Please send us questions as you think of them via the chat function. Look over to the right on the bottom of the control panel. The very last item is a chat bar, and you can send in questions. As you think of them all the way through, time allowed, we'll answer them at the end. If not, I promise each question we'll answer by email as soon as possible after the webinar. Everyone will also receive a link after the webinar with the videotape, so you can watch it again, you can share it if you have others who weren't able to watch. And at the end of the survey, at the end of the webinar, there is a survey that will launch as soon as you exit the webinar. We would very much appreciate your feedback. Next slide, please. Our faculty today is really an experienced and talented couple of folks that are good friends for many, many years and experienced in patient care of all procedures, experts in the lap band. We have Christine Wren Fielding, professor of surgery from the School of Medicine, Division of Bariatric Surgery at NYU, Langone in New York City. Mark Watson, professor of the Department of Surgery at University of Texas Southwest in Dallas. And their stories overlap very nicely in their beginning, and they will explain. And we'll move on to our first presenter, Christine. Welcome and thank you for joining us today.
Well, thank you so much for having me. Hello, everyone, from the hotbed of COVID City here in New York City. So we're well and alive because everyone is always asking about us, but we're doing great, and numbers are down. So thumbs up to that. Next slide. It's really, really great to be here and to talk about best practices. So I'm going to give you a little bit of background. You know, some of my old friends like Vern do know my story, but because I'm so old and I've been out of it for a while, I'll give you a little summary. So back in 1999, over 20 years ago, I did my fellowship at Mount Sinai Medical Center. At that time, I spent 6 months with Barry Salke, but I also spent 6 months with Michel Gagne. And he was the only show in town doing bariatric surgery. And I really knew, the only things I knew was gastric bypass and duodenal switch, and that's how I cut my teeth on my career. And so when I finished, I started the bariatric surgery program at NYU, which is in Manhattan. And it wasn't until a year later that I learned about the lap band and went to a workshop in Louisville, Kentucky, led by Jeff Allen, where George Fielding and Matiku Bilashev were faculty. And I said, wow, this lap band is pretty darn easy compared to a duodenal switch laparoscopically. But what I thought was quite confusing in the gray zone was the adjustments. What in the world are they talking about, these band adjustments? How do you do it? If they're hungry, tighten them. If they're not, loosen or leave them alone. I had no idea. So I said, Vern, send me to Australia to spend a week with George Fielding, because he's apparently the guy. And I did. I spent a week watching him do bands, but 4 out of the 5 days I was there, I was in his office learning from him and his staff on how to adjust bands, and not just how to technically do it, but what to do, how to evaluate the patient, and then decide what to do. And that was the beginning of our relationship, literally. So then a couple of months later, George came over. I had 8 lap bands on the schedule, and he proctored me. Since then, I've done just under 3,500 bands personally. And we still offer, listen, bands are down, we know that, but I'd say 25%, 20% of our operations are still lap bands. And now we've got 4 surgeons, coming from me, we have 4 surgeons, 3 NPs, 1 PA, a bunch of dietitians, psychologists, social worker. And we've also, about 7 years ago, added on a non-surgical program. And essentially, in a year, we perform 1,300 cases. And in a month, we see 1,000 patients that come through our door in the office. So it's a pretty busy practice. Next slide. And that equates to about 150 patients per day that walk through our office. So having said that, lap band, aftercare after any bariatric surgery is important. And certainly the band is not an exception. And when the FDA did their trials 25 years ago, they said, listen, you only have to do 4 visits a year, and then let's see how it goes. Well, since then, things have changed, and most of the adjustments back then were under fluoroscopy. And so band tightness at that time was dictated by how tight the band was as the barium went through it. However, as the decade went on, a lot of the surgeons who did a lot of lap bands got together, and we put together sort of like what is the optimal aftercare for lap bands. Next slide. And what the advisory group, which I was one of them, came up with is that in the first year, after a patient has their lap band, they should have their post-op visit regularly a week after, and then be seen once a month for the first year. So that equals about 13 visits in the first year. And then after that, you should see the patients anywhere between 1 and 6 times in the second year, and then annually. Next slide. And what happens during these visits? Well, in the first month, you'll see the patient post-op a week after surgery. And not only do we call our patient, you should call your patient about a day or 2 afterwards to make sure they're doing okay, but then an esophagram or an upper GI should be done just to verify the baseline esophagram, baseline band placement, and then we'll do a post-op check. And then they'll come in for their 1-month visit. And it's going to be 4 to 6 weeks after their surgery. And that's where you should evaluate their lifestyle, their diet, exercise, their recovery period, and then do they need their band adjusted or not? Are they having trouble with their lap band? Should they see the dietitian? Should they see the psychologist? Maybe they need to come to support groups, and then exercise and talking to them about exercise. Next slide. Month 3 through 12 is essentially the same. It's really listening to the patient, evaluating how they're doing with their lap band. Do they need an adjustment, or do they need adjuvant care by a dietitian, a psychologist, or an exercise physiologist? If they're having issues, upper GI issues, then we may get an x-ray to make sure that they don't have a band obstruction or they don't have a slippage, even though it's rare in the first year. And then sometimes we'll offer them body composition analysis because maybe their weight loss is very slow and you want to know what their REE is. Next slide. After 12 months, well, you can see them as frequently or as infrequently, depending on how their understanding of the band is. And it could be still every month, or it could be every other month, or every 3 months. But suffice it to say that we're doing the same things each time, and it's just an evaluation of how they're doing and what their band can do for them. Next slide. So the question is, how do we do it at NYU? If we're taking care of almost 8,500 lap band patients that we've performed in the past 20 years, and we have 150 patients coming through the door every day, how do we do it? Well, our lap bands are now outpatient procedures. They get a phone call from the case manager of the hospital 1 to 3 days after surgery to make sure they don't have any problems. And they do this for all bariatric operations, sleeves, gastric bypass, and actually it's the sleeves that really need the aftercare call because they're the ones who get dehydrated. The lap band patients tend to have no problems or minimal problems. And then they'll come in a week after surgery to see our nurse practitioner, and they'll get a baseline esophagram at our radiology department, and then we'll review the esophagram and reinforce their post-op diet. Next slide. We also have, and this is usually done by a nurse or a nurse practitioner. They then come in for their 1 month, and that's ideally done by the physician, the surgeon. It's probably the most important visit that these patients have because we'll review how they're doing, but then they get introduced to the green zone chart. And that green zone tells you, Do they need their band tightened? Do they need it loosened, or are they fine? And not only do they learn about the green zone chart, but then they learn about what an adjustment is, because most of them are quite fearful. So I usually tell them, I know you're thinking that this is going to be hurt. I prepare them. I never use lidocaine. I just use an alcohol swab and a Huber needle, stick them in, and they realize that a lot of their anxiety was because they didn't know how painful it was going to be. So it's always good for an experienced physician or clinician to do this. And then they'll learn about the drink test afterwards, drink some water, make sure you're not gurgling or vomiting, and then stay on 2 days of liquids and 2 days of purees. Offer them a visit with a nutritionist. We have them in our office right then and there, encourage support groups, and then they don't leave the office without their next visit. Very important. Make your appointment on your way out. I'll see you next month. Next slide. And then this is how we go. And this is the green zone chart. We have it in a poster framed in every single exam room, so that when the patient comes in, it takes 10 seconds to say, hey, how you doing? How's your family? And then, where do you think you are? Read what's in the yellow, read what's in the green, read what's in the red, and tell me where you are, what describes you the best. Next slide. And that is the introduction to what is my band doing for me, and if it's not doing it for me, what do we need to do about it? And if you do this every single time, your initial 20-minute visit will go down to 5 minutes, because they then understand what each zone means and what that means in translation to their band. For example, if there's any difference in they go from yellow to green, yellow to red, then we can discuss, well, why did you go to red? And you can talk to them about whether is it behavioral, they're eating too fast, they have large pills, or were they over tightened? And there's this interaction that you start to bring the patient in and engage, and then all of a sudden they are taking control of their lap band. Next slide. So again, if they get it after 7 months, then you can say, you know what, you're doing great. You haven't needed an adjustment in the last two times. I'll see you in 2 months. I'll see you in 3 months. There are people who have done so well that after a year, I don't see them for a year, and then I still see them once a year. In addition, we try to do annual esophograms, and we recommend that as just a routine thing, because sometimes patients either are asymptomatic or they will deny that they have any acid reflux, or they're vomiting in their sleep because they know deep inside that that means their band needs to be loosened, and they'll deny it and they won't tell you, but you can see it on an esophagram. So I like to do an esophagram every year, because sometimes you can identify problems early that can be fixed or addressed beforehand. Next slide. And sometimes we'll do endoscopies. I don't do routine endoscopies on them, but if they're having a lot of acid reflux or heartburn, I have no problems doing an endoscopy on them. You don't always have to loosen their bands. I think if they have acid reflux or heartburn when they're lying supine, they should have their bands loosened prior to any procedure, whether it's endoscopy or any non-bariatric surgery. Next slide. So why so many follow-ups? Well, in 2004, I looked at our patients with my fellow Roy Shen. Next slide. And we looked to see if the weight loss changed, or what the weight loss was, right? So in a year, we had 186 lap bands. They had a 44.5% excess weight loss at that time. But when we drilled down and we looked at the patients who came in 6 or less visits, or more than 6 visits in that year, we found that there was a statistically significant increase in weight loss if they came in more than 6 times. We got a 50% excess weight loss, and that was significant. When we looked at our bypass patients, which we had 115 at that time, we got a much higher mean excess weight loss of 66%. But when you drilled it down and you saw that they came in more than 2 visits or less than 2 visits, which was the average, there was slightly higher weight loss with the patients who came in for more than 2 visits, but not statistically significant. So it does have a greater impact on patients overall, but with the lap bands the most. Next slide. In addition, there's been study about what's the impact of regular postoperative visits and the effect of distance from the center where the patients are being taken care of. And this is out of England. Next slide. And this included lap bands that were performed. And in the left-hand side, you see that as the number of visits in the first year increased, then the percent excess weight loss also increased, as described by the most right, on the left side graph, it's the most right-sided block, that they lost anywhere between, about 60% of their excess weight loss. And in the right-hand table, even though it's very small, basically what that says is the farther the patients lived, the fewer times they came into the office and the less weight they lost as compared to the people who lived closer. Next slide. And that sort of dictates which patients I may say, you know what, maybe a lap band's not going to be good for you if you live in like 3 states away, or if you live in another country. Maybe if you don't have access to post-operative adjustments, then you shouldn't have a lap band. Okay, so this paper actually looked at the effect of support groups on weight loss in lap band patients. Next slide. And this is out of Texas, my friend Adam Smith, and they found a linear correlation between patients who went to support groups. They had more weight loss than patients who had a lap band and didn't go to support groups. And I think that there is a lot of other data that shows that for different bariatric operations. Next slide. And it's probably about engaging the patient and keeping them in the fold and excited. So if you don't, so the way that we've done at NYU is that, number one, we have an open door policy. Patients can come in, and it's very easy for us because we have a lot of NPs and PAs who know how to do band adjustments. Second of all, we've established satellite clinics. Right now we have 9 different clinics that the surgeon actually goes to in 4 boroughs that patients can come and get their bands, do their post-op visits, but mostly with the band. But really now what we have in our armamentarium is telemedicine. And telemedicine is the new black, meaning it helps everyone. The patients love it because it's so convenient. They don't have to take time off from work. They don't have to wait in the waiting room. They don't have to travel to the practice, and they don't have to pay for parking. In New York, that's a big deal. If you can't get parking at a meter, which only goes for 2 hours, you have to pay anywhere between $50 and $75. A lot of money. And especially now with COVID, it's been great because it's practice efficiency. We cannot pack 150 people in an 8-hour day in our office anymore. So because the staff can't socially distance and the patients can't socially distance this way, staff can do video visits at home. Patients can do video visits at home and improve outcomes, and now it's billable. So even though we get paid like $15, it's a billable visit. And we've been doing, during COVID, we've been really utilizing this for all patients, especially those who don't need an adjustment. But we've always been available to do emergency band loosenings. And now, as we've opened up our office this week, we are taking in person only those patients who need their band adjusted or they need a physical exam. Next line. And just one more thing, my final slide is that telehealth coaching works. Regardless of whether you have surgery or no surgery, if you're trying to lose weight, if you have telehealth coaching, those patients typically lose twice as much weight as compared to those people who don't have telehealth coaching. Next slide.
Great, thank you very much, Christine. Very clear. There's an underlying message in there that I'll ad-lib for you that sounds like you like seeing these patients, and talking to you and George in the last 2 months, televisit, the online has worked, but you actually miss the contact, seeing the patients. And that's an underlying characteristic that's very important that we kind of can't infuse or have the data on variable, but it certainly matters. You have to want it, you have to kind of like doing this. So then the question comes, you have a lot of patients, you do a lot of aftercare. Not everybody has done all the aftercare. A lot of people have actually stopped taking care of band patients. And in the country, we have probably many thousands of band patients in the wind, sort of the walking dead, sadly. And Dr. Mark Watson, professor of surgery at UT Southwestern, has had a unique experience and observation with this. that he will go on to share very specifically how he's handled rescuing some of these patients. Mark, take it away.
Well, thank you, Vern, and thank you for having me, and hi, everyone across the world. This is something I've had a passion for some time now. My start is different than Dr. Wren's. I was initially trained by Dr. Soper at WashU to do Nissen foam plications when laparoscopy just first started. So in 1992, Dr. Soper trained me how to do a Nissen, and it became sort of my signature procedure for the next 8 years in practice. So I did a lot of fundoplications in California. And as things became more difficult to practice in California, a gentleman I trained with at WashU, Dan Jones, another past president of SAGES, recruited me to UT Southwestern. And as I'm in the process of transferring to UT, Dan said, you know what, there's this new product of the lap band. You ought to learn how to do it since you operate up there all the time in that position of the body. And so he talked me into going to a workshop in New Orleans to learn how to place the lap band. I had not really done any bariatric procedure, but since that was my position was to work on the GE junction, I said, okay, I'll learn how to do that. So we flew to New Orleans, and I met Dr. Provost, who became my partner for the next 10 years at UT Southwestern. And we were both trained at New Orleans by Dr. O'Brien and Dr. Fielding on placing the lap bands. And again, that wasn't my initial emphasis to want to do that, but since they trained me how to do it, I said, well, I'm gonna go ahead and give this a try. Next slide, please, Sandy. And so the adventure started with the Vandals, and it was John, Paul, George, and Vern. And John is John Dixon. He was another person that trained us in our workshop in New Orleans, and it became an adventure for the next couple decades. Next slide. Rapidly, as the FDA approved the lap band in 2001, the safety record, the efficacy, and the ability to reverse to normal anatomy became apparent, and the band became the most common procedure in the area. And we did a lot of them between Dr. Provost and I. We're doing 5 to 10 a week, every week, and it became a passion. I was taking care of these patients. I got involved with it. I wrote a book for patient delivery, and it became something I was very interested in. Next slide, please, Sandy. And as Dr. Wren just pointed out, the follow-up of the band is not just only necessary, it's absolutely required to make these things work. The band is a procedure and a tool to allow safe weight loss, which is efficacious, but it is entirely dependent on you taking care of these people. They require follow-up, they require adjustments, and it is important to do this. You have to be prepared for taking care of it. And like Dr. Wren pointed out, I have been relegated to doing almost all the band care at UT Southwestern. There are 4 bariatric surgeons. I'm doing all the band care. And I have a staff of 2 nurse practitioners, a nurse, a dietitian, and a PA that help me with the band care. And that is the critical part of making this work, is you've got to have people to help you with. They have to be able to be trained to take care of these people and understand what's going on with them. Next slide, Sandy. Again, the efficacy is entirely dependent on how you take care of it, and it is work. And because it's work not only on the patient's cooperation, but also the surgeons to take care of the patients and do adjustments, that amount of work may have led to the band's decline in number. As other procedures were introduced, other procedures became more popular because they didn't require that constant involvement of both surgeon and patient to make it work. Even though during this whole time they were able to demonstrate that the band was still efficacious, safe, and effective. But the decline in the numbers, band became the least favored operation rather than the most favored. Next slide, Sandy. In in the North Texas area, we have estimated 100,000 lap bands that are in this area, southern Oklahoma, North Texas, Louisiana. There's a lot of bands here, and most of them were placed in almost a factory style. And so the emphasis was not on taking care of these patients, it was quickly getting these bands in. And unfortunately, my experience is that a lot of these bands have been cared for by over-tightening in an effort and a misunderstanding of that was what's going to create the greatest weight loss, when in fact, it created the opposite. It caused what we call a band failure. And the band failures are extremely frustrating to me because the two primary reasons for calling it a band failure are two things. One is they're having intolerance to most solid foods, and the other is they're having poor weight loss. Anyone that takes care of a lap band knows that these are the two primary indications that you're in the red zone. That's inappropriate adjustment. And so I see these patients, they come to the office, and they initially come with the intention of having their band removed. Next slide, Sandy. So let's explore what we can do with this. Instead of having the policy of just removing the lap band, what we do is we go in and we do a complete history and physical. We'd like to get the prior films, and we want to see if we can correct this. The majority of the patients that come in, next slide, Sandy, that are coming in from St. Elsewhere have told me that they have all of the fluid out and they still can't swallow. And so the first thing I do is I access the band port and I take out fluid. And what I did is, after evaluating this, I looked up at my nurse practitioner, my lead nurse practitioner, said, gosh, we're seeing the same story over and over again. Next slide. So we pulled the first quarter for December through February of this last year. And we found 8 patients that had come just with that story, that they came with the intention of having the band removed and for significant symptoms. First 3, daily vomiting, reflux vomiting, and this could go for a period of time. Next slide. And in the fourth column, you can see I accessed all these ports and none of them had 0 in them. Most of them had a significant fill that, following removal of that fluid, resolved all their symptoms. And then once you have the ability to sit with them and say, you know what, this is a process, we need to take care of this and we need to follow it appropriately. You have the band, you have the equipment that can allow you to lose weight, and I'm sorry that you've been vomiting for 10 years or vomiting for 8 months or having chest pain or all the other things that we see. You don't need to have that. We just need to take care of this appropriately. And like I said, I think that there's a lot of patients that ended up in this pattern where they got overfilled in an effort, an inappropriate effort to try to lose more weight. And they've instead had the opposite success in that. Next slide, please. So rescue or saving these bands is possible. The majority of them are poorly cared for. It is more complicated to take care of someone that I didn't initially put the lap band in. The reason for that is there's a process before surgery of education and counseling the patients to let them know this is how this works, this is what you're going to do, this is what we're going to do, and we're going to make this work. We can demonstrate this is effective, but you need to go into the lap band placement with the understanding that this is a tool and this is a group effort. And unless they're cooperating, it makes it very complicated. The patients that go into having a lap band done thinking that they're going to get that piece of silastic and their weight's going to disappear are the most difficult to take care of. So these patients that I'm looking at have frequently not been supported in their education to know what exactly they have to do. So it becomes very frustrating when I have to drop back and say, look, you know, we need to actually take care of this appropriately. It's worth doing. You don't probably need another operation. We just need to get back to the basics of how we run a lap band. And it's been rewarding. It's been absolutely rewarding that it takes someone that's been feeling miserable for years or a decade, and in 5 minutes I can make them feel better. And that's pretty darn rewarding. It generates a lot of referrals. It generates new band referrals. Patients, families, and friends are interested in also having this sort of benefit. Next slide, Sandy. So my philosophy on taking care of these is you have to take care of them. Most patients don't want another operation. A lot of them come to the office saying, I want my band out, I want a sleeve. But when you actually talk with them, they're not really excited about having another operation. And most of them, I don't believe, need one. They need to have proper care. And I also, another standpoint is I don't think it's as a public service. I don't think it's a great interest to have patients just automatically converted from bands to sleeves or bypasses. This is not without potential risks and complications and another procedure, and which a lot of times is not necessary. What we need to do is we need to take care of these bands. And so that's what I try to promote here at UT, and I try to help with my partners and my residents and fellows to say that we just need to take care of them. And it is work. It requires effort, but it doesn't feel like work if you like taking care of these patients, if you want to take care of these patients and you know what you're doing. If you don't know how to take care of a lap band, it can be very frustrating on getting it to work right. Next slide. If you need to do something, then do it. Port revisions are just the quickest outpatient procedure. And a lot of times these patients have not had their port anchored appropriately, and the filling process can be very painful and frustrating to everyone. It's a very short procedure just to re-anchor or replace the lap band port. And I need to encourage people to do that. You have to check. And you have to see, is the band in an appropriate area? Do we need to revise this band? You have to check for these things or you're not going to be able to do it. And automatic conversion to a sleeve or bypass, I don't think is the best first step to take. Next slide, Sandy. Literature supports this. This first study is from 2006 with Jaime Ponce, and he's in Georgia. He has reported on 1,275 patients. And this is between 2000 and 2005. So a good number of these were perigastric placed bands, which had a higher incidence of slippage and other problems. And of these 1,200 patients, 40 required repositioning, and only 2 had to be removed following the repositioning. And what he found was he had a good estimated excess weight loss of 48% after revision. So it isn't worthless to go ahead and revise these bands. Next slide, Sandy. Another report from the Netherlands, from Beauvais, from 2012 was looking at 301 patients of hers and 50 extra patients, and they had a 14% patient, 14% or 43 patients that were revised. And what they found was that 76% of the ones they were revised were able to continue or increase their weight loss. So it was a worthwhile procedure. Next slide. Next slide is from the NYU group, Wren and Fielding, and this is looking at their report of from 2001 to 2008 of 3,876 patients. And looking at that group, they had an overall revision rate of 11% or 411 patients. And they found this is a worthwhile procedure. It's found that if you just remove the band, they can demonstrate over and over again that they're going to see rapid weight gain, and that's not in their benefit, and that they have increase of 7% after revision of their loss of excess body weight. The other good findings that they found is that salvage is possible, but if you revise a band and they continue to have poor weight loss, then that is probably an indication to look at converting to another procedure. Next slide, Sandy. This is a graphic representation that the revision is an efficacious mission. Next page. Next slide, please. So many of the patients have difficulty for months or even years with their lap bands because they've been misadjusted. And some of them, and I remember looking at Morella, my nurse practitioner, and because we hear the same lines, we'll have patients that have had 3 or 4 consultations from other physicians and specialists to look at the problems that they're having with their voice or their lungs or their reflux or difficulty eating and all these different problems. And I can just think, most of these are a result of being in the red zone and being over tight. This is a problem with operator error. It's not a problem with the lap band itself. Next slide. Salvage to be done. Salvage is a win-win for everyone. It can avoid other procedures and complications and problems and get a patient back on course with a procedure that works well and will be very productive for them. So I really encourage, and I'm training my residents here and my fellows and my other faculty here, that we need to really work with this, because the band is effective, it does work, and we just need to take care of it. Thank you. Next slide.
Fantastic, Mark. Very, very clear. So you actually have a fairly significant slice of your daily practice or routine of new patients that you've never seen before coming into the program. And that's okay. You have a way to accommodate, and in fact, it grows your practice?
It grows the practice, because what I find is a good number of these patients that come in and they just come for me for aftercare. And what they'll find is they say, you know, well, I really like my band, and, you know, my brother or, you know, my sister or someone else or my best friend, they would like to have this as well. And so I'm getting new band referrals from that practice. And
in the past, our fellows courses, we heard feedback after they left and gone into the wild and done band management, that they actually found it to be an interesting way to grow a brand new practice when they had no cases. So it's very appealing in a number of ways for a surgeon to think about taking care of these patients. Well, thanks very much. And then what happens if they can't be salvaged? What happens next? So we'll go to Christine Wren again to talk about when necessary, when are revisions really necessary, what are the right things to choose from. Thank you, Chris.
Thanks. So, you know, just a segue from what Mark was saying, about 2016, 4 years ago, we published a paper looking at that, exactly that. How many patients did we come in as new patients who had lap band surgery elsewhere, and what did we do for them? And it was 569. 569 patients who had lap band surgery elsewhere came to us, and 40% we were able to help them lose weight with just adjustments or medication. 40% had some sort of revision of a port or a band, and 20% had conversions. And they all wound up doing really, really well. So yes, it is a very easy way to grow your practice. So just getting back on track, you know, again, I'm speaking to a lot of people who accept that obesity is a chronic multifactorial disease. A lot of people do not, even though they say it, they do not act on it or behave that way. Why? Because it appears that a lot of people believe that just one operation treats all bariatric patients, bariatrically obese patients, when in fact, that disease model doesn't apply to diabetes or high blood pressure, right? So that's why I've never denigrated any operation, sleeve, bypass, I mean, mini bypass, whatever, or lap band, because I think every one of these operations has a place for each individual patient. And so I think that lap band still continues to be one of those very, very important options for a certain group of people. Next slide. And it would be nice to know which group of people, but at the end of the day, you're going to get weight problems with any operation. And the one thing we know about the band is what are the problems and how do we treat it? But when you do have a patient with a band problem, try to identify what is the issue. What are they complaining of? Is it that they never lost weight? I lost 15 pounds and that was it. Or did they lose a lot of weight but then have gained it back? They lost 100 pounds, they gained back 50 pounds. Or is it acid reflux? Do they have GERD? To identify whether the GERD is during the day or is it just at night? Those are two different entities. And when they say acid reflux, is it food reflux or is it really acid? Do they have vomiting? Do they have regurgitation? Do they have food intolerance? Or do they have pain? So all I know is that if a patient comes to you and they say, Doc, I lost 80 pounds, I need 10 more pounds to lose, should I have my band removed and have a sleeve put in? The answer is no. No, no, no. Because that means they have no idea what a sleeve is because they think you're putting it in. And second of all, doing that operation will not give them the extra 10 pounds. Do not remove the band. Next slide. Because I've done that. That's bad. They gain weight actually. So evaluate the band integrity. First, look at the band. Is it properly adjusted? Is it broken? Is that the reason why they're having problems? Take a history. Know what type of band you have, what size they have, and how much fluid there is in there. And as Mark says, sometimes they either don't know or they have it wrong. Perform an exam. Is the skin overlying the port red or infected? Maybe it's a band erosion. And then access the port yourself. Always verify on your own how much saline is in the band, because if there's no or little saline, maybe they have a leak. If there's a lot of saline, then maybe it doesn't need to be tightened, or maybe they have a problem, structural problem with the band. Next slide. Then do an esophagram. A flat plate itself can show you if there's tubing disconnection, but then when you run the barium through, you can see what's the functioning of the stoma that the band is creating, right? So if it's rapidly emptying, but they have 14 cc's in their AP large band, then you know it's got to be something structural. Maybe it's an aneurysm. But what if they have no fluid in their band and there's no emptying? It's a dilated esophagus. Well, maybe it's an occult slip, maybe it's pseudoachalasia. So then I would go to an upper endoscopy. Sometimes you'll see a band erosion, or you'll see esophagitis, and then sometimes we'll need esophageal manometry to look at motility issues. Next slide. And these are just examples of ways the patient come in with a band failure, right? So going from left to right, that flat plate shows you that the metal connector of the tubing is all the way down the pelvis, this connection. This band is causing an obstruction and esophageal dilation. Next one's hiatal hernia or a band erosion. Next slide. So these are all different reasons for band failure. And now, what if you find none of that, right? Then then you have to look at, well, what are the other non-band reasons for weight loss failure or regain? Is it maladaptive eating? Is it self-sabotage? Is it sabotage by others, a mother, a spouse? Is it eating out of boredom, eating for reward, compulsive eating, eating out of depression, where people are using food as self-medication for undiagnosed depression? Or is it biochemical sugar dependence? Next slide. So ask yourself, if it's a band problem, address the band. But if it's not a band problem and it's one of those the issues that I just talked to you about, ask yourself, if you take that band out and do something else, will it address that issue? If a person is eating out of compulsion, would taking a band out and giving them a sleeve help them, or should you give them Vyvanse, right? Or if they're eating out of depression, maybe they need an antidepressant. So ask yourself, what problem are you trying to treat? And then manage the patient's expectations. Is it that they need to lose 100 pounds because they never lost anything with a band? Is it that they still have type 2 diabetes after losing only 50 pounds and they need to lose another 100 pounds? Or is it that they just need to lose another 20 pounds? So ask yourself, what is the patient's expectations and what can you provide to them? Next slide. And there's really limited evidence to tell you what to do. Do you revise the band? Do you take the band out? And do you do something else? And what is it that you do? But that's why the number one thing you should try to do is address the non-surgical issues first. Have them see the dietitian. Have them see a behavioral counselor. Have them do an exercise program. Have them see the psychologist or come to support groups. And then give them drugs. There are so many good medications out there between Contrave and Qsymia, phentermine. I love phentermine, use that because it's pretty safe. And also the GLP-1 and GLP-2 agonists. They're really, really terrific. And you can really help them as an adjuvant therapy before sending them to an operation where you really don't know how they're going to behave. Next slide. Weight-wise, how they're going to behave weight-wise. And this is just touching up on one of the issues about pseudoachalasia, because there's a lot of people talking about, well, the band causes achalasia. Well, back in 2011, we still work with Dr. Traub, Morris Traub. He's an esophageal specialist. And he just talked about 6 patients of ours who had manometry, and they basically had aperistalsis. So we emptied their bands, redid the motility study except for one. And one patient, one had normal peristalsis, 2 had partial return of peristalsis, and they all had clinical improvement except one, and that one person actually had their band removed. But the other patients, they have had improvement with loosening, and and it doesn't mean you have to race to take out the band. Their band is still providing them something, but what we've done is added some sort of medication. And then, of course, if they become symptomatic with an empty band, then we'll take it out and do a gastric bypass. Next slide. So what are the options? Take the band out and do nothing. Revise the band or replace it. Take the band out and do a sleeve. Take the band out, do a gastric bypass. Take the band out and do a duodenal switch. And then the question is, if you're going to take the band out, are you going to do it in one stage and then wait a couple of months and then do another operation, or are you going to do it simultaneously at one time? Next slide. And the MBSK QIP data looked at 30-day complications of patients that were matched going from band to sleeve to band to bypass. And if you look at the bypass column, they all have almost twice as many complications of leaks, 2.5 times the complication rate of bleeding, twice as many complications of 30-day readmits, and two times higher reoperation rate in 30 days. And there's still low numbers, but the message here is that if you're going to do, if you're looking for the safer option, it's band to sleeve as opposed to band to bypass in 30-day complications. Next slide. But how about the weight loss results? Well, we looked at our data and we found that the patients who had their band out to sleeve have a higher weight regain. They lose less weight in the top curve, and they gain more weight in 5 years, going from a BMI of 43 to a BMI of 39.5, where the bypass patients go from BMI of 43 to a BMI of about 33. So clearly, the weight loss is better overall when you go from band to bypass, but there's slightly higher chance of complication. Next slide. So then there's going to be patients who say, well, listen, my friends have all had a sleeve and they have done amazing. So I say, when did they have their sleeve? They say, oh, 8 months ago. I said, of course. So find somebody with a sleeve who's had it 5 years ago. They can't find them because those people have typically gained some weight and won't tell anybody that they've ever had bariatric surgery. But be that as it may, I say, well, having a band to sleeve is very different than going from nothing to a sleeve. And as our data has shown that at 2 years, patients who've had a straight off primary sleeve lose much more weight than patients who've had a band out to sleeve. And we don't know why. Maybe it's a metabolic thing where their metabolic rate went down after they've lost weight with the band. Maybe they know how to maladaptively eat. We don't know. So I just tell them, this is the data. Next slide. And I usually try to steer them towards a bypass. But all I know is that the patients who should not have a band to sleeve are the ones with acid reflux, the ones with esophageal dysmotility, gastroparesis, maladaptive eating, sugar dependence, type 2 diabetes or insulin resistance, if they're postmenopausal or they have limited activity, because they need an operation that's a little bit more extreme that will give them very big restriction, gut hormone changes, and increased satiety, and possibly dumping so that they don't go towards the sugar. They have a different aversion. Next slide. So in conclusion, gastric banding, it may not lead to optimal outcomes for everyone, but it certainly is a good first step. It introduces people to bariatric surgery who would never want to have surgery. I think if they do have trouble with the band and they have weight loss failure, weight regain, which happens with all operations, you have to really identify whether it's the device, whether it's us, me, you, or if it's the patient. And try to address poor outcomes with non-surgical options first. I can't tell you how much adjuvant medication really augments what the band does, especially liraglutide, like Saxenda, Ozempic. They do brilliantly. It really amplifies their appetite control. And give the band a chance with the best practice management, because we've certainly been able to salvage some of these band patients. And then when it's time to take the band out, then you'll have to really think about what you're going to do, whether it's a bypass or sleeve. Next slide. I have one final disclosure, and that is my husband, George, has had his band for 20 years. This past December was his 20-year anniversary of his band. He's kept 95 pounds off. He goes up and down 5 or 10 pounds. He won't tell you that. But he's got about 81% excess weight loss. And he still has that 10 centimeter Intimate lap band. He's never had anything like changed, removed, converted, revised. It's pretty amazing. So it's been always reminding us that it's a pretty good product. It's not crap. You shouldn't just throw it away. So thanks so much. Next slide.
Thank you very much, Christine. That was very nice conclusion. And on the last webinar, Chris shared that even his daughter has now had a lap band, and that's believing in it. That's confidence. Mark, if you come back on and join us for some questions, we really appreciate you getting through such content so efficiently. There's a lot was just covered. A couple of key themes. Both of you are aware it's a lot of work, but you're okay with that. You're up for that. And your teams have been geared up for that. The amount of time it takes for the aftercare, how does that balance out? A question came in. Do you ever spend any time in the OR if you're doing all this aftercare? And how can you afford that?
Mark?
Well, you have to have a team, okay? And so I typically will have a nurse practitioner or a PA is seeing a lot of these people while I'm in the operating room. And they're sophisticated enough that they know if they're out of their league that they can wait or call me and consult with me to find out if there's something else we need to do. But they're very good. After several years, they figured it out that if you see this, we need to go to upper GI. If we see this, we need to take the fluid out. It becomes there really are physicians extenders, and that's what you need, because I can't be doing that while I'm in the OR. And it's been more complicated during this COVID time in that I've ended up still seeing patients when I'm not supposed to, because sometimes they need fluid out. And so I put my N95 on and go take their fluid out. I mean, it's just silly to not do that. But you have to have the extenders, and also you just have to segregate it. I have a lot of clinic time. I do three clinics a week, and I typically will see about half are going to be lap bands, and a lot of those are going to be taking care of bands that were put in other places, and just sort of have to make room for it. Like George pointed out at the last webinar, it's not a lot of work if you like doing this. And when you know these people, I've had bands in for 15 years in people, and you get to know them and their families, and you've watched them go from someone that can't walk to someone that's walking 2 miles a day. So I mean, it's really rewarding, but you have to like that. We can't convince you to like that.
Yeah, I think that's beautifully put, because that's why I think the first month, like the first adjustment, and the 1 year adjustment or 1 year visit should be done by the surgeon. All the visits in between can be with a nurse practitioner or a PA. That's why we have 3 of them. We have 1 PA, and they all know. They'll text me while I'm in the OR, or they'll say to the patient, you know what, your next visit, you need to see Dr. Wren, Dr. Fielding. So, and yeah, I do 3, sometimes 4 clinics a week. So it's a lot of clinic, but you have to like it. You have to not mind doing primary care.
There's some really good questions have come in. Mark, a really practical question. Of the patients you have rescued, how many of them eventually still may need their band removed?
That's a guess. I don't have hard numbers on that, but I'd say a good 10% of them are still going to need their band out. And there's certain things you have to look at. Like we pointed out, that if you've revised a band and changed it and they still have poor weight loss, that's someone that needs to be converted. Fortunately, I have 4 other partners that I can easily refer to have evaluation for a sleeve or a bypass. And the other people that have trouble are the ones that people aren't Fords or Chevys. And so you put the same lap band on a bunch of people and you're going to get a different pack of results. And you point this out all the time in our lectures, Vern, but sometimes the band doesn't work for a patient, and we can put the band in perfect, we can adjust it perfect, and if they just feel poorly, then that's the band that needs to come out. The reason for having a band, the only reason for having a band, is to make you comfortable eating less food. If you're not comfortable with your band, you shouldn't have it at all. Okay, and so that's the beautiful thing about the band, because I take care of a whole bunch of gastric sleeve patients that I can't fix them at all. With the band, I can fix them.
Chris?
Yeah, no, absolutely. And I don't think that a band that is not working, or, you know, we have, in most of our insurance companies, require these 6-month pre-op sort of weight management or weigh-ins. And you know what, I try to tell the patients and use this positively. I say, listen, I can take your band out and do a bypass on you, but you're going to have to wait 6 months. You're going to have to do the monthly visit. So let's take this 6 months as a way to get, this is a trial separation. You and your band are going to be separated, and we're going to try to work on re-getting together, right? And trying to make it work, like counseling. And after 6 months, if it works, great, we get back together. But after 6 months, if it doesn't work, we do a divorce, and then we take your band out and we have the 6 months for the insurance, and we're good.
So that really leads to, there's a couple of questions I'm going to mash together here. How many times do you have a conversation? What kind of effort is involved in talking a patient into letting you try to salvage them versus let's just have it out? And what is that conversation like, Mark?
Usually it doesn't take that long. I wouldn't think it takes 30 minutes, but you have to back up, because if they're not my patient, they didn't get the preoperative counseling and the understanding of what the heck's going on in the first place. So you have to bring them up to speed. And so I tell them that. I said, look, I didn't know you before this, but this is the way the band works. The band does work. I can prove it works. But unless you do X, Y, and Z, it makes it very difficult. And so I drop back with all of them and I say, the initial reason I'm seeing them is they've been vomiting, having heartburn, they've been feeling crappy. And like I said, all the patients that I saw in the last quarter, I took all the fluid out and they all felt better. And I think you have to step back and say, look, well, let me try this. And I do. I haven't had anyone refuse that yet. I said, let me try just taking the fluid out. Let's see how you feel. Let's get the upper GI. You talk to the dietitian, and let's give it a break and see how we work for the next couple months. Now, I usually require a couple months before I do anything else.
Is there data that tells you how long to wait and what the outcomes will be, or what is, you have to take it out and wait and see, or what can you advise on that?
Chris?
Out for esophageal dilatation to resolve.
Oh, the esophageal dilatation. Oh, okay. So if I've gotten them the esophagram, they have esophageal dilatation. I empty their band. I give them at least 3 weeks because they're terrified to wait any longer. And usually by 3 weeks, I'll repeat the esophagram, and 9 times out of 10, they have a significant improvement. If they do not, that's when we have a conversation about, well, an empty band has not improved your esophageal dysmotility or dilation, and let's give it another 3-6 weeks and we'll see. But if it's not better, then we're going to have to talk about taking your band out.
I'm not aware of any data that tells us exactly what the metric is. That's an open area that there hasn't been a large population to research, is one thing, but its clinical experience around the world is exactly what you've just said. They won't tolerate it being out very long before you decide to put it back or do something. 3 or 4 weeks. We're running down on time. Why do you think patients end up so over-tightened in the first place? How does that happen? Chris?
I mean, in our population, the reason why is that patients say, I'm hungry. They know what to say. I'm hungry. I'm not losing weight. You need to tighten me. And then I have to, because sometimes they equate weight loss, the more tighter, the more weight loss. So they will sort of determine how tight their band is according to how much chocolate or how much ice cream they can eat. So I tell them, can you eat vegetables? Can you eat salad? And when they say no, and I say, I want you to have your band tightened in accordance to how much solid food you can eat, not how much sugary stuff that you can eat.
Mark?
Yeah, both are responsible. So there's patients that we call them fill junkies. And the fill junkies just assume and know as a fact that if I give them more fluid, they will lose more weight. And I spend a lot of time saying, you know what, that's not the case. I can actually demonstrate the opposite. When you get too much fluid in there, you're going to gain weight. And then the other is we got these surgeons, especially in Dallas. We had factories that were putting in 8 to 10 a day, and it went for years. They can't do that if they're taking care of patients. And so the easiest way to take care of the patients is tighten up to a point where they won't come back. And I think that's equal problem with this, is that they're over tightened by the practitioner.
That's painful for me to hear. That's kind of gets me right there, that's actually, but I've heard it from many. I know you're not exaggerating or making it up. And our hope through programs like this is we can expand the network of people willing to care for them. And that leads to really down to the final minute here. If patients from this webinar or friends of friends from this webinar want to find you or somebody in their community that will help them, not find somebody who will just say, you have a band, let's take it out. How do they do that? And I'll answer that one. Lapband.com, surgeon locator, zip code. Internationally, it's a little challenging. Each country has a little different setup, but at the end of the day, call me and I'll find you a doctor nearby that can do it outside of the network. But in the US, we have the locator. A couple things we talked about. You have to want to do this. You have to like doing this. You have to know how to do it. We do have to acknowledge the patient has to have those same three things. They have to want this to work. They have to be willing and able to come back and do the work, spend time with you, and to do what they're advised to do. Take your advice. Eat slower, smaller bites. They can't, like George will say in the courses, you can't live like a person who doesn't have a band when you have a band. You have to respect that it's there and work together. And that's not for everybody. I think a real important message today is that it doesn't work out of the gate all the time, and it doesn't work when tuned up or rescued all the time, but give these patients a chance for it to work before going to the next, possibly more dangerous thing, and something that they didn't want in the first place. So we're out of time. I sincerely thank you both very much, and for our significant audience that's held on with us. I wish you all safety and health in this crazy COVID time. I understand that Monday's a holiday. What is that? I don't know what that is. Please, when this ends, the questionnaire survey will pop open. Please take time to respond to that. And in about an hour after this is done, the entire event will be captured in a video link. Every registered person will receive that link. I encourage you to share it with your faculty, your colleagues, your extenders. And then if you have questions that you weren't able to ask there, you know how to find me, and your Reshape colleagues are ready to help. So with that, we'll have a little going home music. And my choice today was Ariana Grande. Somewhere over the rainbow, the sky will be blue. We'll get out of this. So thanks, everybody. Everybody have a good weekend. Mark,
Bye.
Chris,
Thank you.
great stuff. Thank you
Bye,
very
Chris.
much.
Bye.
Bye-bye.